Great. Hey, thank you very much, Sean. Thank you, Barbara, and Miriam and Carol, other women in the group who really inspired me to speak out in this way. I know some of you aren't here tonight, but I've been asked to talk about fatty liver disease, so I thought I would outline who is the high-risk patient, because the prevalence of this condition is just so enormous, as you'll soon see. Oops, I don't know. Okay. So what is NAFLD, or non-alcoholic fatty liver disease? Well, as the name states, it's the appearance of a fatty liver in someone who is not excessively drinking alcohol. So this ultrasound could be done for many reasons. Often it's because someone may have complained of their belly hurts, they are bloated, or they've had liver enzymes drawn as part of their physical and liver enzymes were elevated, and an ultrasound was the next appropriate investigations to do. Fatty liver disease is now the most common reason for people to have elevated liver enzymes. And while it's most often seen in people who are overweight or obese, it's important to recognize that 10% of patients with NAFLD are lean. And these are people who we think of as having visceral adiposity, or I'm sure you've heard the name TOFI, thin outside, fat inside. Now, just to get an idea of how prevalent this condition is, globally, it affects 25% of the population. That's a lot of people. And it's also found in 2/3 of people who are diagnosed with type 2 diabetes, and it's found in more than 95% of people who are undergoing bariatric surgery. Now, before I pursue more about tonight's topic, it's important to address that there are many other people who could have a fatty-looking liver, but it's not necessarily because of nutrition. So we do a proper history, look at other conditions. So just one slide on this topic. So there are many drugs that will cause the appearance of fatty liver disease, such as people who are taking methotrexate for many years for the rheumatologic conditions. Tamoxifen is a well-known agent that women will be using as adjuvant therapy for breast cancer. And it can certainly cause the appearance of a fatty liver within months. And part of it could also be nutritional, and certainly there's people that do require nutritional advice as well. There are people who are on valproate for seizure disorders, amiodarone for cardiac disease, or people who've been on chronic steroids or high-dose tetracycline. It can all cause the appearance of a fatty liver. Now, it's also important to recognize that there are certain conditions that can also lead to that. And celiac disease is truly a great masquerader within the field of gastroenterology. So when patients may not be having the typical symptoms of diarrhea, anemia, or weight loss, sometimes a fatty liver might be the only sign. What's also important to recognize is that hepatitis C infection, and specifically it is genotype 3, that can make the liver appear fatty, and the fatty liver will go away once the hepatitis C is cleared. In hospitalized patients, we'll see it in people on chronic TPN, malnourished patients, or even anorectics who are now refeeding. So that can also appear. And even though it's termed non-alcoholic fatty liver disease, in 17 years of practice, I have definitely been fooled. So even though we think it's not, and we think we've ruled it out, I still think it's important to come back to it and just question it every once in a while to make sure. So NAFLD, it's important to recognize it has systemic associations. It's starting to become better recognized now that it is, in fact, a marker of metabolic syndrome, even more so than visceral fat. And it's been seen to be a risk factor for people to develop heart disease, hypertension, chronic renal disease, gout, type 2 diabetes, obstructive sleep apnea, and polycystic ovarian syndrome. It's also independently being associated with increased risk of certain malignancies, such as colorectal cancer and even hepatoma. Typically, hepatoma is a cancer we see most frequently in people who have cirrhosis. But NAFLD and hepatitis B are probably the only two conditions that are increased risk of liver cancer without already having cirrhosis of the liver. So the big question, is it NAFLD or NASH, and what's the terminology? Because it can often be confusing. So NAFLD is the umbrella term, and NASH, well, they're both histological terms, but NASH, non-alcoholic steatohepatitis, is the presence of fatty liver, as you can see here in the first picture, with the presence of inflammatory cells and development of fibrosis. Whereas NAFLD is the simple steatosis of the liver without any evidence of inflammation or fibrosis. Now, the way to diagnose, to distinguish the difference is percutaneous liver biopsy, which is the gold standard. With that, though, there is cost and there's complications, including pain, bleeding, and even death is listed of that. Now, with 25% of the globe having fatty liver disease, I do not think it is reasonable to go and biopsy all these people. So hopefully in a few slides down, we'll have a better approach to this. So fortunately, we have liver elasticity or FibroScan. And this is a non-invasive way to assess not only hepatic fibrosis, but also hepatic steatosis. And this is very, very accessible in Canada, more recently accessible in the US and in Europe. So this is a completely non-invasive test. There's a few companies around the country that provide this service, and some hospitals even have their own. And it's a machine, which is right here on wheels. It takes about 5 minutes. And the technician places one of these wands up to the right costal margin of the patient, and they take about a series of 10 readings and take an average. And the probe is passing in through the person's body a wave, and it measures back the stiffness. And that bounce back wave correlates very nicely with histological stage that one might see on a liver biopsy. Now, the lower the kilopascal score, that correlates with a softer liver and less injury, whereas a higher stiffness score correlates with more hepatic fibrosis, possibly cirrhosis, and more advanced disease. Now, a CAP score is what measures directly liver fat content, and it's categorized as mild, moderate, or severe. And it's a very useful tool because it's non-invasive. You can do this repeatedly over someone's treatment course to see for progression or even regression. These are two tools that I use in addition to FibroScan and to help me decide if someone needs a liver biopsy. Now, there's the NAFLD fibrosis score, and there's also the FIB4 calculator. Both are validated for fatty liver disease, and they're both available on MD Calc or whatever online app you may use for medical calculations. I prefer the FIB4 simply because I have to input less data. So it asks for the age, the AST, the platelet count, and the ALT, whereas the NAFLD fibrosis score uses age, BMI, AST, ALT, platelet count, and albumin. Both of them will spit out a number, and it will tell you if they're low risk of having advanced fibrosis or high risk of having advanced fibrosis, and recommending either referral or more investigations to perform. So I use these if I don't have a good correlate with my liver scan or with ultrasound, platelet count, or other surrogate markers of advanced fibrosis that I do in my office. Another tool that's available, but I do not have access to this, is called MR elastography. And it is a little bit more valid than liver scan, and I'll explain why in a moment. So with liver scan, there's a wave going through a person's skin and in through the liver. But if somebody has a very thick abdominal wall, it can sometimes lead to overestimation, whereas an MRI would not, because it can account for that and is looking directly for liver fat as simple steatosis, or inflammation but no fibrosis, or the presence of fibrosis. And the other caveat to FibroScan is that if somebody has a significantly inflammatory disease, such as their liver enzymes are in the hundreds, well, as you can imagine, if their liver is swollen from inflammatory cells, it would potentially lead to an overestimation of liver stiffness. So in somebody with an acute hepatitis, FibroScan it's not the right timing to do a FibroScan, but with MRE, that would not be an issue. It's just not as widely available. So NAFLD is just one part of this whole thing, and it's probably the clinical event of all of metabolic syndrome, which we're going to come and talk to you about. But just to see on this slide, you have a healthy liver on the left. Once you get the correct exposures and you get de novo lipogenesis, you will get a glistening fat liver, and that's what fatty liver looks like, and that's present from 25% and up to 40% of some populations. There's a waxing and waning approach or process that goes on in the liver over years with inflammation. It might calm down a little bit, inflammation again, and any illness or anything that causes chronic liver inflammation will lead to liver fibrosis and eventually cirrhosis if the process is not halted. That's the same thing like in hepatitis B, hepatitis C, autoimmune disease, or alcohol. Fatty liver disease is exactly the same thing. If the fire fueling the NASH does not stop, a person has a high risk of going on to developing progressive fibrosis and cirrhosis. And as I mentioned earlier, NASH or NAFLD is one condition that can go directly to increased carcinogenesis without someone actually having cirrhosis. With all other diseases, once someone is cirrhotic, they're then at increased risk of liver cancer at a rate of about 4% per year. Now, the other big issue with cirrhosis, this is a picture that I show people in my office after they've had a fiber scan or liver biopsy. I'll let them know whether they're stage 0, which is normal. Stage 1 is mild fibrosis. 2 and 3 are moderate. 3 and 4 are advanced fibrosis. Stage 4 is when you have complete nodular formation on histopathology, and that is the definition of a cirrhotic liver. When someone develops cirrhosis, they get impaired vascular flow through the liver, and this leads to changes in sinusoidal pressure. So when somebody has cirrhosis and alteration in sinusoidal pressure, they're at risk of what's called decompensated cirrhosis. And this occurs in about 20% of patients after they've been diagnosed with cirrhosis within 5 years. So it is a high rate of this conversion. And what a decompensating event is developing of esophageal varices or variceal hemorrhage, development of ascites, which is development of fluid in the abdominal wall, development of hepatic encephalopathy, or liver cancer. Now, when any of these things develop, that's called decompensation, and they carry a 50% mortality within 2 years. So it's certainly a big deal if any of this happens, and this is why we care so much about preventing someone from developing cirrhosis so that they do not develop these complications. Now to understand, again, coming back to the burden of disease. Now this was data published in 2018 in Hepatology, and as I was saying earlier, NAFLD affects 25% of the population. This is exactly true looking at US data, where 85 million have NAFLD, 17 million have NASH, and 3.5 million have advanced fibrosis. And this is the population that's going to go on to be at risk of decompensated liver disease and the complications of cirrhosis. Now, what's also important thing to recognize is that we always think of alcoholic liver disease being the top reason for liver transplantation. And prior to that, it was hepatitis C infection. Well, since we've become so amazing at eradicating hepatitis C due to antiviral therapies we've had, NASH has now overtaken hepatitis C as a leading cause of liver transplant in the US in 2016. And this is also happening in Canada. Now, again, coming back to what's going to happen with people who have advanced fibrosis. Well, a number of them that are going to worsen with disease is only going to skyrocket. And it's predicted that by 2030, the number of people that will have increased rates of decompensated cirrhosis will go up by 160%, liver-related deaths by almost 180%, and liver cancer by almost 140%. So all of these issues need emergency room visits and hospital visits. So for those who are listening who do hospital-based medicine, this is something that we're going to be seeing more and more often. And just to comment about who these people are, is that when someone often has decompensated liver disease from NASH, they're most often a brittle diabetic, bad heart disease, poor mobility, poor physical endurance. So they almost end up being palliative at very young ages because they're often not considered candidates for liver transplantation given their significant morbidity in general. So who are these people that are at highest risk of cirrhosis? Well, this was taken from the NHANES data, and it shows that without a doubt, people with type 2 diabetes are at the highest risk for developing progressive liver disease from NASH, followed by those that elevate a BMI, which is obese, hypertension, and age. So you'll look at this and you go, I know who these people are. Those are the same people, and they basically classified it as metabolic syndrome. So let's look at what's happening in Canada. So 2/3 of Canadians are now either overweight or obese, and 1/3 of our children are overweight or obese. And I find that number terrifying because as these children grow up and become adults, they're going to carry with them their burden of disease that they've acquired at a young age and just only get worse and have complications of their diseases very early in adulthood. And I do not think the medical system is going to be prepared for this. Globally, Canada ranks 5th in terms of countries where obesity is prevalent. And compared to 1980, the prevalence of obesity for adults has doubled, and for children, it has tripled. So what got us here? And now I have to thank Barbara for lending me this slide and a few others coming down. But you can't help but deny what happened prior to the 1970s and afterwards. And in the early 1970s, what came out were the low-fat guidelines. And they came out, and I'm sure a lot of you in the audience already know this stuff, but just to remind ourselves that low-fat guidelines were advised because it was thought that high-fat intake was what was leading to heart disease. So as a result, everyone was told to eat less fat, and what's happened is that BMI rates have continued to climb. So despite the low-fat guidelines, and you can see obesity rates climbing, well, what have people done? Well, if you look at the composition of macronutrients, protein has essentially stayed the same from the early 70s to the 1990s. Fat intake has gone down as advised by the greater powers above, and carbohydrate intake has continued to rise. So this is certainly something that cannot be ignored. Now, when I get referrals for people with fatty liver disease, very commonly the referring physician will comment, and I have told them to stop eating fat. Or when I talk to patients, they go, but doctor, how can I have fatty liver disease? I don't eat any fat. But as soon as you do a detailed dietary history, it becomes quite clear. And it's also important to educate people about, well, an example is what is foie gras? So foie gras is a delicacy, it's fatty liver, and it's been known for centuries how to create it. So this is the purposeful creation of fatty liver, and it's not done by giving these geese fatty meals. It's done by giving them excessive sugar, fruits, and cornmeal. So in this example, and I'm not an animal activist, I eat everything, but I don't eat foie gras just because I'm a hepatologist. But generally, these animals are kept sedentary, they're not allowed to move, and they're being force-fed by a process called gavage. So in humans, if we also eat all day long and don't make the best nutritional choices, you can see how it's so easy to develop fatty liver disease. So one thing that's also important to explain for ourselves and for our patients is that sugar hides. Food producers are very clever at how to hide the name sugar under other names, but it's important to teach people that honey is still sugar, brown sugar is still sugar, maple syrup is still sugar. But even if it's natural, if it's sweet, it's still potentially going to add some harm to your body. Now, I like this slide because it's super simple, and I kind of use this to help with teaching my patients. But bad carbs are the starches, too much sugar. When we eat too much of them, we do make our serum insulin rise. And when our serum insulin rises, it's doing that to allow our cells to allow glucose to enter our cells. But when we have so much insulin running around our bloodstream, the cells simply just don't respond as well. And then a process called de novo lipogenesis occurs, and fat is then produced out of our sugar stores. As insulin levels continue to stay elevated, this just feeds back into our system to make us hungry, make us have cravings, and often eating the things that are most readily available and make us feel the best quickly, which end up being those starchy carbohydrates. So it's easily a cycle that many people fall into, mostly because they really just don't have a good education or understanding about nutrition. So coming back to that, this was a study published in J Hepatology 2 years ago by Jensen's group. And they looked at the NHANES data and looked at NAFLD, obesity, and sugar consumption. And you can easily see that this all goes together. So a nice diagram they had in this study was looking at fructose mechanisms and fructose ingestion and how it relates to fatty liver disease. So fructose ingestion does several things. It's directly affecting the adipocyte. It directly affects our gut microbiome, affecting the tight junctions, which determine how nutrients are absorbed and what inflammatory markers then go through our portal system and into the liver. Fructose also directly affects the liver. And fructose is metabolized differently from glucose. And the things that fructose does is it will lead to direct de novo lipogenesis and fat production, which then is also involved in increasing hepatic insulin resistance and reduced beta oxidation. The lipogenesis and steatosis also causes mitochondrial dysfunction and oxidative stress. And through mechanisms involving cyclic AMP and xanthine oxidase, high uric acid levels also result, which further promotes more lipogenesis and inflammatory reaction and hepatic fibrosis. So it's a cascade involving multiple areas of our body. And when you tell someone to reduce fructose ingestion, as a gastroenterologist, it does affect their microbiome. They actually feel better. So it's not surprising that we're seeing these mechanisms drawn out nicely. So just to go through a few little studies, this was a study published in Gastroenterology in 2015, and it was a 12-month prospective trial of paired liver biopsies in 260 patients, looking at the evidence for weight loss in people with elevated BMI and NASH. So this was done at a tertiary care center in Cuba, and they recommended a low-fat, calorie-reduced diet. And even though it's calorie-reduced, you can see that 64% of the diet was carbohydrate-based. And they also advised people to walk for 200 minutes a week. And what they found was the greater the degree of weight loss, the more significant improvement in histopathology. And they found that 10%, if people could achieve more than 10% weight loss, this was associated with improvement in all features of NASH, including portal inflammation and fibrosis, showing that this feature is reversible. They found that if people could achieve a 5% weight loss, that stabilized their situation and improved fibrosis 94%. However, by the end of the study, only half were able to achieve and maintain a 7% weight loss. But even with 7%, if you can achieve 5% weight loss, you are still having some improvement. Now, this was a study published in JAMA last year. And again, all of these studies are very small. And this study looked at the effect of a low, free sugar diet compared to usual diet on NAFLD in adolescent boys. So this was a randomized controlled trial, open label, looking at an 8-week trial of boys age 11 to 16 who already had biopsy-proven NAFLD and NASH and elevated ALT. The intervention was menu planning and keeping the free sugar intake under 3%, which is very low. And they provided the study meals for the entire household versus usual diet. And the outcome was looking at hepatic steatosis by MR. PDFF, I didn't mention this one, but it's a type of MR called the proton density fat fraction. So it looks at the fat dropout based on MRI. So it's similar to MRE in terms of what it tells you. Anyway, they did the MR at baseline and at 8 weeks. And they found that of these 40 boys, who most are Hispanic, all completed the trial, but the degree of hepatic steatosis loss was greatest in the intervention group. So it was evident to show that just having these adolescents significantly reduce their sugar intake will have a benefit in as quickly as 8 weeks in improving fatty liver disease. And of course, the recommendations are larger studies are needed. So it's quite clear that sugar is connected to NAFLD and metabolic disease, and weight loss helps. Large studies still lacking, and many small studies will suggest a link of sugar and fructose and NAFLD and obesity and metabolic syndrome. And we also know that certain studies by industry will often show no effect, but you have to question that there is some bias there. So as clinicians who see patients, without any statements being made by the greater bodies of our specialties, are we wrong to advise patients to reduce sugar and fructose intake? Personally, I don't think so. And I think it's important that we all learn facts about sugar and its consumption. And one thing I've learned from practice is that telling someone to lose weight just does not work. If you engage people and tell them a little bit of information on how to lose weight, I'm amazed at the difference that it's given to patients. They just spend a little bit more time with them, teach them how, and the results can be really quite impressive. Another message I want to send home is that fatty liver disease, even without fibrosis, is not nothing. Because nothing makes me cringe more than saying, NAFLD without fibrosis is benign. It's not benign. And I say it's not benign because while that person may not actually get fibrosis or cirrhosis from the NAFLD, they're still at risk of all the things related to fatty liver disease, which is heart disease, diabetes, sleep apnea. So those are all very important things, and they still deserve the same counseling because fatty liver disease is a marker of insulin resistance. So let's talk about what we're all going to do. And I think a lot of you in the audience already understand this, but it's to understand sugar math. So understanding that 4 grams of sugar is 1 teaspoon, and that's 1 sugar cube. Now, Barbara has lent me this slide as well, and that's looking at what are the WHO guidelines for sugar intake. And these came out in 2015. And Canada has still not made a statement on this. And personally, I'm working with our own public health board to see if we can make this more easily accessible to patients other than seeing me one by one as we're doing in the office. So how much sugar is enough? Well, women should have no more than 6 teaspoons of sugar a day, men 9, and children should have no more than 3 spoons of sugar a day. And you'll soon see how easy it is to blow this budget. So how much are we eating? Well, in the early 1900s, people were consuming on average about 7.5 teaspoons of sugar a day. By the mid-1970s, about 17 teaspoons of sugar a day. And by the mid-90s, 27 teaspoons of sugar a day. And currently, it's about 30 teaspoons. And most people can't even believe how that's possible. But it's possible when you look at what people buy. So just an example, let's look at what's in the grocery aisle. So Fruit Loops, and most of these cereals are very similar. So 1 cup of dry cereal, no milk added, has 12 grams of sugar, which is 3 teaspoons. A bowl of oatmeal it's in here, it also has about 13 grams, which is 3 teaspoons of sugar. And that's without adding any milk. The child hasn't had any fruit or anything else. So by breakfast time, most kids have blown that sugar budget. Nutella, how we all love Nutella. Not, but 1 tablespoon has 11 grams of sugar, which is about 3 teaspoons. And most people don't stop at 1 tablespoon of Nutella if they're going to use it. Now, fruit yogurt. Now, as a gastroenterologist, I feel awful that I even ever recommended probiotic yogurt to my patient, but I did years ago, and that's because before I ever really realized and appreciated how much sugar was in them. So 18 grams of sugar in 1 little container of fruit yogurt. So for a woman, that's basically 5.5 teaspoons of sugar. She's reached her sugar budget for the day in just 1 fruit yogurt. And many people will have 2 of these a day if they have one for breakfast, and they may take it with them to work for lunch. So let's look at some sugary drinks. So this is a bottle of Simply orange juice, although all of them have the same amounts of sugar. And this one's vetted by the American Heart Association. So 1 glass, that's 8 ounces, has 26 grams of sugar, which is just over 6 spoons. A glass of whole milk has about 3 spoons of sugar, and a glass of chocolate milk is about 6 spoons of sugar. This is apple juice on the left. 23 grams of sugar is about 6 spoons. And a can of Coke, just for perspective, has 39 grams of sugar, which is about 10 spoons. Now, when I talk to I'm an adult physician, but when I talk to my patients, many of them are parents, and we'll talk about this, and I say, well, would you ever give your kid a can of Coke? They go, no, I would never do that. But as soon as you educate them that a juice box and a fruit yogurt equals a can of Coke, they're often just blown away because people don't think of sugar math in that way. And a lot of kids are getting that kind of stuff on a regular basis. Then we wonder why childhood obesity is sitting at the numbers it's currently sitting at. So the next topic is carbohydrates. So net carbs are what I advise people to learn about because I want them when they go shopping to try to buy products that have the least net carbs. So that's where you take the total carbohydrate minus the dietary fiber and you end up with the net carb. The fiber is the good stuff. So you want stuff with lots of fiber. So it's important to recognize that carbohydrates, when broken down, become glucose. And the cells in our body do not know if that glucose that's floating around came from sucking on a lollipop or if it came from a bagel. It has no idea. So just to, there's many different studies that have been done looking at low carb, high carb, low fat. And as you know, this is a very highly debatable topic in media. But one study I want to point out, I'm sure most of you read it, is the PURE study published in The Lancet a few years ago. And they looked at with 130,000 patients in 18 countries and was prospective. And their bottom line was that reducing carbohydrates, not fat, should be the focus of dietary guidelines. And in fact, they found people that consumed a higher fat diet was actually associated with a lower risk of early death. So let's look at diet in general. Now, this was a study published in 2019 looking at the beneficial effects of Mediterranean diet over low-fat diet. And they looked at which one decreased hepatic fat content the most, because hepatic fat content is better correlated with cardiac disease than visceral fat. So they looked at about 278 patients with obesity and high triglycerides, and they utilized a workplace cafeteria as the place for intervention. So they gave people either a low-fat diet or a Mediterranean low-carb diet, and they actually measured it at 40 grams low-carb, which is very low, plus 28 grams of walnuts a day, which is about a handful of nuts. And they did MR elastography at baseline, week 6, week 18. And of these patients, majority were male, half of them had NAFLD, and 40% had metabolic syndrome. And what they found after an 18-month intervention was that the people who lost hepatic fat content the most were the people on the Mediterranean low-carb diet with the walnuts, compared to people who were on a low-fat diet. And in fact, the difference was quite significant in terms of the drop in hepatic fat content, as well as their measurable outcomes for cardiovascular risk. And this effect was seen beyond the loss of visceral fat. So how low is a low carbohydrate diet? So the average Canadian consumes more than 300 grams of carbohydrates a day. And if you look at the standard diet on the left, you can see the majority of the macronutrients that typically people consume is carbohydrate based, followed by a balance of protein and fat. A low carb diet places the carbohydrate intake between 50 and 120 grams, depending on how strict somebody wants to be, followed by fat intake and protein intake. Whereas a ketogenic diet is very low carb, about 20 to 30 grams a day, where fat is at the largest source of calories, followed by protein. So just looking at example, the differences between products people can eat. One bagel has 51 grams of net carbs compared to one slice of whole grain bread, which has 20 grams of net carb. So just to show people how to read a label, it can teach them a very important difference in the choices that they want to make. Just a slide on starches that people fill their plates with, because they're used to them. A bowl of what seemingly is a healthy pasta. One bowl of dry pasta, no sauce on it, has 58 grams of net carbs. So 63 minus 5 is 58. 1 cup of cooked quinoa has 34 grams of net carbs, but it is also a source of protein. And if you look at your brown and white rice, you're sitting at a net carb intake of about 21 grams for brown rice and 23 grams for white rice. So there's not actually a substantial benefit in brown rice compared to white. So quick tips and quick ways to swap out carbs. So instead of spaghetti, try spaghetti squash, zucchini noodles. Instead of bread, try swapping for a lettuce wrap. It amazes me how many things one person can do with the cauliflower, but it really is the best vegetable out there. And instead of mashed potatoes or rice, you can easily use a cauliflower in either form. Also, I recommend people swap out their flour for coconut and almond flour because it is a higher fat content, leads to more stable blood sugars. And there's fortunately many sites online where people can get recipes on how to utilize these items. The key there, though, is getting people to cook. And a lot of people are too busy, although they've just forgotten how. So trying to encourage them to do so is also part of the battle. So since we're dealing with a very fat-phobic society, often people forget, well, what is a good fat? So I recommend people consider avocados, cheese, eggs, fish, nuts, olives, seed butters. I kind of hold back on the coconut oils because many of my patients do have heart disease, and so I'm not comfortable pushing that yet. But I recommend full-fat yogurt, full-fat milk, and dark chocolate. The one thing I recommend to almost everybody is intermittent fasting, and I'm sure most of you are familiar with it. So the other name for intermittent fasting is time-restricted eating. It is not the same as starvation. It is voluntary, and it's purposeful cycling between a defined period of fasting and non-fasting. And when people fast for more than 14 hours, your body will mobilize your lipid store and utilize it as energy in the form of ketone bodies. And our body does so very efficiently. So people can fast 1 or 2 days a week, but I do see if I can engage people to do it every day because I think it makes it a routine for them. And the one thing I find patients like is having the sense of control or empowerment over what they do. So I try to recommend 16 and 8 if they can do it. I mean, I know that there is optimal times of fasting and eating by 2 p.m. and fasting from 2 p.m. onwards, but you also want people to have success at it. And part of that is trying to engage socialization and doing it with their families. So I try to recommend what will work best with their work life and family life. So we know that fasting can produce weight loss comparable to calorie restriction. There's lots of evidence now that it increases insulin sensitivity, it reduces oxidative stress, and there's evidence that it slows aging. And there was an excellent review article in New England Journal about this just a few weeks ago. And funny enough, they did not mention NAFLD in it, but it's a great review article if you haven't come across it yet. So pharmacotherapy, are there any drugs for people with fatty liver disease? The answer is no, not yet. So I'll just quickly review what has been done. So there have been studies on insulin sensitizers and incretin mimetics. So there have been little evidence of histological efficacy with metformin, so that really does nothing in terms of NAFLD and NASH. It does insulin sensitize, but it doesn't help the liver disease. Linaglutide, a GLP-1 inhibitor, or an analog, improves NASH, but not fibrosis. And there was also a concern about its tolerability, so that study was quite limited. There was interesting data with PPAR agonists such as pioglitazone, and it was better than placebo, and it improved all the histological features of NASH, except it did not do anything about fibrosis. So as a result, it's also not recommended. Now, in terms of antioxidants, there is data for vitamin D, and I do recommend this for all patients, especially living in North America where we're very commonly vitamin D deficient. So I recommend vitamin D 1,000 to 2,000 IU a day, depending on their BMI. Caffeine has been found to be helpful in fatty liver and in preventing fibrosis and in reducing the risk of liver cancer. So if people can tolerate it, I do recommend 2 to 3 cups of black coffee or with cream a day. So definitely not a double-double, but black coffee or with cream if they can tolerate it. Now, there has been data on vitamin E that it does improve hepatic steatosis and inflammation and even some NASH. But in the studies, it increased all-cause mortality from heart disease. And as a result, we can't really apply this widely to many people, and many in my practice are at risk of heart disease, so I can't really offer it to them. And there was also a suggestion that it increased the risk of prostate cancer. Lipid-lowering agents, statins, have not been adequately tested in NASH, so there isn't necessarily a striking benefit for it, but there's also no harm. So if people with NAFLD have hyperlipidemia and need a statin, they should be on a statin. Elevated liver enzymes is 100% not a contraindication to statins. So to review pharmacotherapy, from people with simple fatty liver disease to NASH to cirrhosis, lifestyle modification is key, statin if indicated, and even bariatric surgery for the morbidly obese has shown to be helpful for fatty liver disease. Insufficient data for everything else. And if they are cirrhotic, they need screening for esophageal varices and hepatoma, as I mentioned earlier in my slides. Now, there is stuff down the pipeline. So Gilead has a few drugs in combination, looking at lipotoxicity, fibrogenesis, and inflammation. So it's a 3-pronged approach. And that's because pathogenesis of NASH is clearly complicated and it is multifactorial. So their first drug, selonsertib, unfortunately did not pan out, and I'll show that in the next slide. But their firsocostat, which blocks de novo lipogenesis and beta oxidation, in conjunction with cilofexor, which is involved in bile acid signaling, does show promise. So I'm just showing this one slide out of the many for the sake of time. So selonsertib did not do anything, but the combination of cilofexor and firsocostat did. And this is looking at MRI PDFF, or fat fraction, where it causes significant reduction at week 12 in patients on combination therapy. Now, what's interesting is that they're using this information, and now they are, in combination with Novo Nordisk, doing a trial right now, and it's a proof of concept combination study using semaglutide, a GLP-1 analog, with the FXR agonist and cilofexor. So the people in this study are patients with biopsy-proven NASH, stage 2 to 3 fibrosis. And so I'm looking forward to seeing what happens, that hopefully we'll have something for our patients with advanced fibrosis. Now, Intercept is also a company that has a drug in the race. And this is a slide from the Regenerate study, which is a phase 3 international randomized placebo-controlled trial of obeticholic acid. So obeticholic acid is a potent FXR agonist as well, and it's been shown to have direct anti-fibrotic effects in the liver. Now, this is a drug I already use for patients with PBC, also called primary biliary cholangitis, which is a chronic liver disease that leads to cirrhosis from chronic cholestasis. So I use obeticholic acid as adjunctive therapy for people with ongoing cholestasis. And I use it at a much lower dose than what's in this current study. And the one thing about this study is that at its 18-month interim analysis, it did reach one of its primary endpoints, and it received breakthrough therapy designation by the US FDA. And what they did achieve was that it improved disease activity due to NASH based on the key histological parameters. So it'll be interesting to see what comes out of these studies in the next 1 to 2 years. So coming back to what do we do with our patients? This person's in your office, what should you do? Now, we all would like weight loss, and my targets are not normal BMI, because sometimes that can be difficult for patients. And we also have to have realistic goals when dealing with people who do have obesity. But we know that achieving 7 to 10% weight loss can help resolve their NASH. So we do try to encourage them to do that. But as I said earlier, you can't just say weight loss, thanks for coming, see you later. It's important to try to give them some tools on how to. So I do teach them about the WHO guidelines on sugar intake. I tell them to avoid sugar, avoid fructose. I advise them to really truly minimize alcohol intake. And we spend a lot of time talking about macronutrient composition. And I do recommend a low carbohydrate, healthy fat diet for my patients. I recommend almost all do intermittent fasting. And I find the fasting is even easier for patients who don't like to cook, because at least that's one meal less that they actually have to make for themselves. So I find fasting is actually an easy sell when you try to tell them all the things that you want them to try to do. I recommend vitamin D, vitamin E for some, and there's also some evidence on choline deficiency. Now, choline, funny enough, comes from eating eggs, fish, nuts, and those are basically high-fat foods. So people don't necessarily need to take a supplement, but if they eat those foods as part of their healthy fast, then they will hopefully replenish that. There's lots of evidence now about sleep and how regular sleep is so important in regard to preventing insulin resistance. So this is something that's important to advise people about, as well as physical activity. And you want people not only to walk or run or do things for cardiovascular fitness, but I also encourage them to do some muscle training. And as I mentioned before, I recommend coffee consumption without sugar for those who can tolerate it. So to summarize, the high-risk fatty liver patient, who is it? Well, those are people who have type 2 diabetes, elevated BMI of obesity, hypertension. Those are the strongest predictors of them developing advancing fibrosis. And we truly want to prevent that from happening. As a liver doctor, I don't want them to develop cirrhosis or any of the complications that I've mentioned, including variceal bleeding, ascites, hepatic encephalopathy, because with all of those three, they're on the way to liver transplant if they're eligible candidates. Understanding that NAFLD and NASH is an indicator of the process already in motion, and it is reversible with lifestyle modification. Wanted you to appreciate that FibroScan and FIB4 are very easily accessible, non-invasive tests to help predict fibrosis, and they can also assist in motivating patients. And I find people after a year may want to repeat their FibroScan to see if has that fat content actually gone away or been reduced. But it also helps determine who may need a specialist referral, because again, if 25% of the globe has that, they can't all see a hepatologist. So we want to just know who are the highest risk people who would benefit from seeing a specialist. Aside from that, though, if people have chronically elevated liver enzymes, that is also an indication for referral, because other things other than fatty liver disease could be causing that, and that needs to be assessed as well. So our goals are to teach people to optimize and modify their lifestyle. And that's while we recognize the enormous contribution of excessive sugar, starchy carbohydrates, and non-stop feeding that has led to poor metabolic health for many people, and recognizing that it's all the same disease. So I just have one more slide. I don't know if any of you have read this book, but page 17 totally was fixated in my mind. And the author, Yuval Harari, took this data from WHO from 2012. So I'll just end by reading it. In 2012, about 56 million people died throughout the world, and 620,000 of them died due to human violence. War killed 120,000, and crime killed 500,000. In contrast, 800,000 committed suicide, and 1.5 million died of diabetes. Sugar is now more dangerous than gunpowder. And thank you for your attention. I'll hand it back over to Sean.
Thanks so much, Supriya. Quick question for you. At what stage of fibrosis do you consider that lifestyle interventions and reduced carbohydrate diets and that sort of thing are not going to be effective? So, what is the point of no return in your mind?
There's no point of no return.
Excellent.
Even when I have patients with ascites in my office or they've had a varicose bleed, if I'm seeing them in follow-up, I definitely recommend no sugar, low carbohydrate. And if anything, those people benefit from more protein intake because they're actually in a very highly catabolic state. So it will help reduce in hepatic inflammation, which may in turn reduce portal pressure because it's the portal hypertension that's driving those complications of decompensated liver disease. There's no point of no return. I guess unless they're palliative and they wish to keep eating with how they eat. If that's the case, I've had people in their 80s and they just can't change their eating habits. So I educate them, but it also comes down to their personal choice. Great.
We talked a little bit before, your talk here about your colleagues and the differences between your approach versus your colleagues. Maybe you could just describe what is, because you're kind of unique. While there's a few of you across the country, but it's still developing. What needs to be done to get other hepatologists and GI docs on board and understanding the power of these types of interventions?
You know what? I don't know. I'll show you my next slide here. I made this handout for my whole GI group. And I've even sent it out to primary care in my whole community where I live. And I know, so this is on our EMR for people, for my other colleagues to print out and give it to their patients. And I don't know how often they're using it, but I know it takes the time to have a conversation. And if it's not something that they're passionate about, they're not going to spend the time to educate patients. Because it's one thing to rip it off and print it and give it to someone, but I think it's way more efficacious to go through it with someone, which is my approach. I'm not in the office with my colleagues, but I know that this is probably not their favorite thing to do.
Is there anything that you think is going to be required in order for them to become, this becomes standard of care for NAFLD?
Well, it's a disease that requires counseling, and right now that's not how medicine is remunerated. So I'm kind of doing it for free. But as I'm seeing them for their disease, you give them their disease, but this is not just here's a prescription and go. They need a lot of counseling. So I think the fee schedule, if it allowed for nutritional counseling, that may be one way to inspire other clinicians to do this, possibly. And just more time. The other issue is that we're all sitting with 8 to 12 month waiting lists. So it's hard to have the time to spend. I choose to, but others choose not to.
Well. A couple of questions from the group here, and for those of you, if you have a question that you haven't asked at this point, please enter it in the instant messaging or the chat feature. If you do want to ask the question using your mic, maybe just make a note in the chat feature as well, so that I can call on you and make sure that you get a chance to ask your question. So, first question is. Do you recommend reducing fructose by limiting fruit?
No, I don't recommend elimination of fruit. because it's a little bit different. So fructose in a drink, there's none of the other benefits that you would have from eating a fruit. So with the fruit, you've got other antioxidants that are going with the fructose, and you're eating it with the fiber. So you have, gated absorption, so to speak. And so no, but if people are eating, a bunch of grapes and watermelon and 3 mangoes a day, yes, I recommend you cut back on your fruit. So I just tell people to have more mindfulness and be aware of what they're consuming. But definitely I want people to be off of fructose containing drinks.
Okay. So this one is it's sort of on the controversial side, but just want to get your opinion on it. And that's just related to, you made some comments about statins. What is your thoughts on statins, in terms of, the risk profiles and how best to approach, prevention?
Well, I think if somebody truly has hyperlipidemia and their risk for cardiac disease are high, then if a statin is indicated, they should not be making the liver issue a contraindication to using the statin. That's my point. So I don't prescribe statins. It's not in the realm of my practice. But I know if someone has got, lipid levels of 8 or 9 and we're working on their, mind you, I also push a dietary approach to push their triglycerides down, but there's some people you will not be able to normalize their lipids completely on diet. So if a statin is indicated, then I recommend that they do use it. Great.
Carol's question here, what are your specialty conferences covering this topic?
Well, I presented at our Ontario GI conference, and a couple of months ago I presented at a University of Western Ontario. London had a GI update, so I presented there. But otherwise, it's not exactly a topic that's always being presented. But that's what I've done in Ontario.
Great. Do you or are you
the primary care Lynn talks? I've spoken there as well.
Right. Do you or are you able to utilize dietitians in your practice?
No, I don't have access to any in my practice. They're no longer at the hospital. I'm trying to see if this is something I can incorporate, if I can get some support from some companies to help me fund one, then that's still something I'm looking into, but I don't have one right now. I mean, I do refer some patients who are on insulin to a metabolic clinic, because one of my other colleagues does run a metabolic clinic. So if I have people on insulin, then I will refer those type of people who need more monthly coaching. And she has a dietitian.
Do you have people that you refer to in the community, like from a primary care perspective, to follow up and support your patients who are trying to implement, whether it's carbohydrate restriction or it's intermittent fasting?
Yes, no, I do. I do have a colleague I refer to because I was saying she has a metabolic clinic. So she's a general internist who did the obesity medicine fellowship. So I refer my patients to her if they're interested in going. Otherwise, I manage them on my own. Okay,
excellent. You've talked about sugar and products or foods that contain considerable amount of sugar. Do you have a list, or do you consider anything a bad carb beyond sugar?
Beyond sugar? In terms of food items, you mean?
I'm assuming that's the question, yes.
Well, starchy carbohydrates. So people eat a lot of root vegetables. I try to have them minimize it. As an example, I have a lot of South Asian patients with NASH who are diabetic who also are vegetarian. So when I talk to them about their diets, a lot of them will eat bread and rice products and potatoes and lentils. That's basically their whole diet, plus sugar. So I try to encourage them to eat less potato and more of the above ground vegetables. So it all depends what their overall diet is and where I can shift their focus. Hopefully that kind of answer helps.
Sure. Do you treat GERD this way, and do you see benefits of using?
I do. I've applied this completely to my whole practice. I've got patients with IBD who are doing much better on a low carb or even a ketogenic diet. I have every one of my patients I teach this to, whether it's IBS, GERD, bloating, constipation, all of it. Wow. And the IBS people feel tremendously better on this way of eating.
Excellent. How quickly have you seen NAFLD reverse in those who follow low carb plus or minus intermittent fasting?
6 months. Well, that's because that's the interval I'll see them back in. So could be sooner.
Okay. Do you believe there's a difference between just the basic low carb versus low carb Mediterranean for treating NAFLD or NASH?
Not really.
So it's more important around the carbohydrate restriction as opposed to the source of oils?
I guess I know. I do recommend people eat more plants, like plant-based diet that's low carb and good fats. And I just call it all that. I don't even call it a Mediterranean diet when I teach my patients.
Okay.
So yeah, that's the answer to that.
A quick question in regards to Roundup. Do you see any relationship between the use of different types of pesticides and increase in non-alcoholic fatty liver?
No, I don't, but it's funny. I had a slide on that on glyphosate. I took it out just because of time constraint. So yes, there are studies looking at glyphosate exposure measured in the people of urine with NAFLD compared to those who did not have it. It's not something that I see in my practice, but I know that it's out there. So wanting to wash your food, this is where buying organic, I guess, could be helpful. But I also would anticipate that this is being addressed in the food industry, I would think. But it's not something that I have a way of testing for.
Do you use continuous glucose monitoring in helping people to keep their sugars low?
No, not yet. It's something
Okay.
I'm interested in looking into, but not yet.
And sort of an add-on, do you get patients into nutritional ketosis? And if so, do you monitor ketones?
I don't.
Would you recommend that, or do you just not have you're not in a position to be able to monitor?
Yeah, no, I'm not in a position to monitor it, so I can't see them frequently. But those people who are interested, I do refer to my colleague, Dr. Hai, who runs her metabolic clinic. And I'm not sure if she does that or not either. I'd have to ask her later.
Okay. Do you think this approach applies to any other conditions that are characterized by inflammation? So the dietary approaches that you're taking?
I do think so. So I share a lot of patients with rheumatology as an example. And let's say they've been on methotrexate for their rheumatoid arthritis, and I'm seeing them, and they also have abnormal liver enzymes. I'm working them up. And they may have some methotrexate injury, but they also have fatty liver, which is from your nutrition. So we'll talk about it, and we'll put them on a lower carbohydrate diet, on a high-fat diet. Some of them will implement fasting. And when I see them later, not only is their liver disease improved, but they're even on less meds for their rheumatoid arthritis, and they feel better. Their joints feel better. So that's not something that you can ignore. So I've seen it anecdotally.
Wow. You are by far the most efficient answer of questions that we've had. You have ripped through like a couple of dozen questions in no time flat. Very impressed. Do you have one last question here? What blood tests do you follow and how often? And obviously, you mentioned that it's 6 months between many of your visits. What would you recommend in terms of blood tests and the interval in between within a primary care setting, let's say?
Yeah. So depending on how motivated the person is, I will give them blood work to do every 3 months. So it kind of gives them a target and lets them know that I'm watching, because I will review all the results. So every 3 months so I'll see them at time 0. They're coming back to see me in 6 months, but they'll do blood work at 3 months and again right before they see me. And I'll monitor whichever enzymes were elevated, whether it's the ALT, AST, GGT, or or those are the most common ones. And then, yeah, that's pretty much it. And if there's something I missed from the beginning, I'll recheck it, like their vitamin D level. But that's usually all that I follow on blood work for that interval to see where those numbers are going.
For those patients that you've included fasting, and let's say a person is doing full day fasting versus just part day fasting, is there any difference in terms of the timing of the blood tests, whether it was an eating day or a fasting day?
No, I don't.
Doesn't make any difference.
It shouldn't make a difference actually for liver enzymes.
Okay, great. John's asked here, is there any way we can get a copy of your patient handout?
Yes.
Great. Well, if you are able to share it with me, what I will do is just make sure that everyone who is part of this, or I might even be able to attach it to the information regarding the webinar, and then people can go back and get it from there. So that would work. Excellent. Assuming there are no additional questions here, I just want to thank you so much for your time. We really appreciate it. This was an excellent presentation and overview of the options, not only dietary, but also it was good to cover some of the medications, and the lack of efficacy of medications is always a great reminder for people in primary care that lifestyle is really the major approach that is going to need to be taken on this for some time to come. So this could be our canary in the mine in terms of really trying to get lifestyle as a standard of care across many inflammatory as well as chronic conditions. So thank you so much for all of your efforts and for the great information, and we really appreciate you spending the time with us this evening.
Oh, my pleasure. Thank you.
Okay, everyone, have a wonderful evening, and we will be back in about a month. We have another excellent speaker who will be joining us talking about food addiction. So we will be I'll be sending you all the details, or Miriam will be sending all of the details out to you in the coming weeks. So thanks again for being here this evening, and we will be talking soon.